Okay, thank you all so much for your patience. I underestimated how hard it is to get from SDSU, and I taught this morning, so it has been a whole day already. But I really appreciate you all coming to this talk, and I feel so grateful to be back here because I am an AD-RCMAR trainee. I got an AD-RCMAR pilot grant a year ago, and so a portion of the talk that I'm going to be presenting today is based on the research that the data that we were able to collect with the funds that we have from AD-RCMAR. So it feels like a full circle moment. And I'm also really excited to hear what you all have to say and what you think of, especially the first study. I'm going to present 3 studies. And the first, we've just submitted this study. So it's in its earlier phases, and any feedback that you give is going to be really valuable at this, especially this phase. So I'm an assistant professor at SDSU, and I'm also a clinical audiologist, and my research focuses on improving access to hearing care for older adults, but also reducing the exposure to noise for workers that are at increased access or increased exposure. But I'm not talking about that second part today. Just some disclosures. The grant that I'm funded under currently is a K-23, and the data that I'm going to be talking about today are funded under the AD-RCMAR grant. I wanted to talk a little bit about myself, not to give a huge personal introduction and talk about myself just briefly, to give you a little idea of how I came to this research. So I'm a CODA. Has anyone heard that acronym before? CODA. Maybe you saw the movie. If you haven't seen the movie, I recommend it. It's a very good movie. CODA stands for Child of Deaf Adults. My dad was born deaf, and we use sign language in my family to communicate. And I mention this because being a CODA has informed my worldview, my view on disability and deafness and communication disorders, and in part what has inspired me to be an audiologist. I got my clinical doctorate at the University of Texas, and there I learned about teleaudiology as a service delivery model to bridge gaps in access to care. So in addition to being clinically trained, I was learning about all the issues that we have in audiology with there being too few of us, and how we can use service delivery to improve care. And then in my PhD, I learned about community engaged models. So on the left-hand side, this is my mentor's project, which she worked with community health workers and had an intervention where people came once a week for 6 weeks to learn about communication strategies to help them with their hearing loss. And on the right, that's my dissertation, where I also trained community health workers, but to use telehealth to fit hearing aids remotely in a border town. And now as a faculty at SDSU, I get to train all of these wonderful students. This is us on a bus trip to Yuma, Arizona, where we went to a farm worker health fair. And in the middle of the night, so from 2 a.m. to 6 a.m., we tested people's hearing and gave out hearing protection. And this is a lab party that we had at SDSU. So I'm getting to use what I learned and spread it to newer generations, but also definitely still learning as I go. So the talk today, I want to talk about hearing loss and its impacts, including on cognition. And then I'm going to talk about 3 studies if I have enough time. And but the first 2 are the most important because these are my AD-RCMAR funded studies: hearing loss and cognition among hearing aid users and non-users, and then a qualitative study, that's number 2, talking about the positive, negative, and neutral views on hearing aids. And then number 3, if we have time, I'd like to talk about over-the-counter hearing aids. And then just some brief reflections on community-engaged research and talk about what's in store for the future. You probably already know, but hearing loss is very common, especially as we age. So this is showing decades of age on the x-axis. On the y-axis is percent of the population. So as we get to be about 70 years old and greater, the majority of us are going to have some degree of hearing loss. It's a public health issue because of all of the range and severity of negative impacts of hearing loss. In addition to, also one of the characteristics of age-related hearing loss is an inability to hear high-frequency consonants. So this is why a lot of people will say, I can hear you, but I can't understand you, because they're missing those high-frequency sounds, so it can sound like parts of a word are missing. So you know someone's talking, but you're not quite sure what they're saying. You're mixing up one word for another. And that can really impact communication and reduce clarity of speech. It also makes it really hard to hear a noise because noise tends to be low frequency or low pitch. And then some downstream negative effects are loneliness, social isolation, and lower health-related quality of life. And then the reason we're here today is to talk about hearing and cognition. There has been an abundance, a growing number of studies that have linked hearing loss to cognition. Here I'm showing a screenshot of a Lancet Review article, which accumulated a lot of studies over the past decades that have shown an association between hearing loss and cognition. Here we can see a number of different factors that can contribute to cognitive decline. And in midlife, the top modifiable, potentially modifiable risk factor for cognitive decline, we can see is hearing loss. The potentially plausible causal pathways, no one has accumulated enough evidence to say one is best over the others. One is sensory deprivation. So if you have prolonged hearing loss, then there are physical changes in the brain, and that impacts cognitive capacity. Another hypothesis is information degradation. So because of that high frequency hearing loss, your brain is working harder to compensate and using up cognitive resources. And then a third is a common cause. So because of aging, hearing loss and dementia are resulting from some similar root cause, like degeneration from cardio disease risk factors. Hearing aids may reduce that risk. So I said it's a potentially modifiable risk factor because it makes logical sense that the number one treatment or management for hearing loss, which is hearing aids, could be a good treatment option, could be an effective recommendation for people to use in midlife to prevent an increased risk for cognitive decline. This is more on a theoretical level. Hearing aids improve auditory input, and so we could imagine that could reduce the risk of cognitive decline because it reduces cognitive load. They also could mitigate sensory deprivation, and they facilitate communication. And so this intermediary effect of social isolation that could be connecting hearing loss and cognitive decline could be addressed through hearing aids. What does the evidence show? Well, we have more evidence from observational studies than experimental studies. So many observational studies have shown that there is a link between hearing loss and cognition, and some have shown that hearing aid use helps prevent or delay that link between hearing loss and cognition, but there are some mixed findings, so not all studies agree. And of course, there's residual confounding. Hearing aid users differ on a lot of different factors compared to non-hearing aid users. There's one randomized controlled trial to date that is longitudinal, and that has compared the effect of hearing aids on cognition and hearing loss. And that's the ACHIEVE trial. Anyone familiar with the ACHIEVE trial? So they looked at hearing aids as an intervention to see if people with hearing loss would, over the course of 3 years, delay their risk of cognitive decline. And they found that there was no overall effect. Their primary results were null, but in a subgroup of Eric, these are a predetermined analysis of a predetermined subgroup who is already at baseline at higher risk for cognitive decline. Among that subgroup, they did have a delayed, a benefit of hearing aids. So they were delayed in their risk of cognitive decline. They had a lower risk of cognitive decline. So not as glowing results as we were all hoping for, but it is encouraging more people to do trials like this. It's so expensive, as you all know, and really difficult to do trials like these. Also, that trial was done in the middle of the pandemic, which is another thing to consider. I also just wanted to put this out there. This is a screenshot, just an image from a hearing aid company called SMADRC. And it says, for people with hearing loss, using a hearing aid is associated with reduced risk of dementia. Now, that's not what I just said, is it? But what I said is a lot more words than what you can put on a simple infographic. So on the one hand, I understand where hearing aid companies are coming from, that they need a pithy, quick thing to put on their advertisements. But on the other hand, if you put my pessimistic hat on, they're kind of leveraging these results, and that's not accurate. So what I would encourage you all to do in your respective positions is to educate patients and students on the actual, these results are subtle, they're nuanced, and they're complicated, but how can we communicate that to the public? Because what they're receiving is this, and that is not true. And so I think hearing aid companies are using this to their advantage to sell $6,000 periods. So what does this have to do with the research that we are carrying out? Well, Latino adults have a low uptake of hearing aids. These data come from the Hispanic Community Health study of Latinos, and they show that less than 5% of Latino adults use hearing aids. These data are pretty old. They were collected at baseline, which was about 15 years ago now. But that is much lower, less than 5% is much lower than the overall US population. So if we think that hearing aid use might be able to help prevent or delay cognitive decline in people with hearing loss, this is a really big issue. There's also, in addition to ethnicity, there are barriers to hearing care for rural individuals, people with low incomes, people with lower education levels, and people without private insurance. Hearing aids are really expensive and they're not covered by most insurances. Because they're high cost, limited insurance coverage, unfortunately, there's still hearing aid stigma and there's a low supply of providers. There aren't enough audiologists to go around. Here's a map of the state of Arizona. Each of those black dots represents an audiology provider. There's a big clump in the middle where Phoenix is, and another clump down below where Tucson is, but there's a lot of the state where there are no audiology providers. So you'd have to travel an hour and a half if you lived up northeast in Apache County to get to the nearest audiologist. So imagine yourself living in Apache County and you're thinking, am I really gonna drive an hour and a half to go see someone so they can tell me something I don't wanna hear, and they're gonna tell me I'm gonna have to buy something that's $6,000. So most people just say, nah, forget about it. And in addition to that, in Arizona, there are only 13 Spanish-speaking audiologists. So of course, not all Latinos are Spanish-speaking, but a lot of them are. And in California, a state with millions of Spanish speakers, there are less than 60 Spanish-speaking audiologists. So definitely not enough to go around. So the summary of the motivation of this set of studies that I'm going to talk about is that hearing loss is common and it's potentially linked to cognitive decline. Latino adults have a number of barriers, and amplification hearing aids may reduce that risk. So the first study I'm going to talk about is the association between hearing loss and cognition, and if that association is weaker among hearing aid users compared to non-users. So the conceptual model is age-related hearing loss and the association with cognitive decline. And we talked about the theoretical linkage between those two being increased listening effort, reduced auditory stimulation. But then if you add hearing aids into the mix, does hearing aid use reduce effort and restore stimulation along that pathway. So the hypothesis is that the association between hearing loss and cognitive decline may be attenuated among hearing aid users. So we did hearing tests out in the community. We went to community health centers and took our portable audiometers as a tablet-based audiometer that allows us to do full diagnostic hearing tests outside of a clinic, outside of a sound booth. And we also collected the MoCA, which I'm sure you're familiar with, cognitive screener. Just wanted to highlight the importance of our community partner who reviewed the IRB. They actually had their own IRB, and they helped facilitate data collection. They reviewed findings. They requested a one-pager from us, which I loved, so that they could share with their clinic partners. So our outcome was a MoCA score, and we're looking at better ear pure tone average. That's an average of 4 frequencies that we collected through the hearing test. And we looked at 4 progressive models where we just added in predictors with each progressive model. With the last model, we had all of the predictors and the interaction term between pure tone average and hearing aid use. So with model 1, it was just looking at cognition and hearing loss. Model 2, we added in hearing aid use. Model 3, we added in age, sex, and education. And model 4 was the whole model plus the interaction term. So we had 97 Latino adults. And here I'm showing you their characteristics separated by hearing aid user and non-user. Hearing aid users were a bit older, but on average, overall, we had similar proportions of males and females. And unsurprisingly, hearing aid users had poorer hearing. You can see that by the hearing loss PTA, a higher number means poorer hearing. The MoCA score, if you're familiar with that score, if you look at that line, the scores are similar between groups, but the score is quite low. If you're familiar with that score, 30 is the highest that you can get. 26 is usually the cutoff for cognitive decline. So that does seem pretty low, right? But we were only referred individuals who were cognitively able to consent and to participate in these activities. So why was this number so low? Probably because of this, because of education. These individuals had very low education. Many of them had no formal education. And the MoCA is not great with that population. So I'd also welcome advice and comments that you might have for tackling that challenge. We weren't able to use the MoCA Basic, which is an alternative, because it wasn't available in Spanish. So I'm not familiar with other alternatives that are available for this population. I also wasn't really expecting this, the education outcomes. So we'll work with what we have. And I'm just showing you the results from the models that we ran. I'm going to skip to model 4, which again was the fully adjusted model with the interaction term, to show you the little asterisk shows significance, to show you that there was a significant interaction between pure tone average and hearing aid use. And that shows us, we did also look at within group slopes, which were not significant. Here are 2 scatter plots that are showing individual data points, pure tone average on the x-axis, so your hearing is getting worse as you're going further to the right, and MoCA score on the y-axis, so your cognition is better as you're going up. And if I were to superimpose those 2 plots, then those lines would cross, so the interaction, you would see the interaction better. But the within group slopes were not significant. And the interaction term was just barely on the edge of being significant. So we can see that the hearing cognition association may differ by sensory axis. So I'm saying that because the interaction term was significant, but then the different slopes were not, we didn't really see anything there. The hearing aid group was quite small. We only had 18 individuals who were hearing aid users. However, that was about 19% of our population. If you think back to the Hispanic Community Health Study population, they were less than 5%. less than 5% of those individuals were hearing aid users. So we're doing better. There's reason to believe maybe more Latinos are using hearing aids. But in terms of our comparison and our analysis, the number of hearing aid users was quite low. So we will need to redo this in a future study with more hearing aid users. But it is important to do this research because there are more and more evidence is showing the potential for hearing aids to address cognitive decline in people with hearing loss. And really we haven't seen a downside to using hearing aids. So if Latino adults are not using hearing aids as much, then there's reason to look forward to opportunities for scalable interventions. And I put a picture of an over-the-counter hearing aid there just as a preview of what I can talk about in a minute. Of course, it's cross-sectional, and like I said, we had a small number of hearing aid users. And in the future, we will try to recruit more. And we can look at other indicators of hearing aid use, like self-report and data logging, which is an objective report, an objective outcome of hearing aid use. We just use hearing aid use, yes or no, which is a pretty gross measure, but that's what we had. Okay, I'm going to move into study 2, which used the same population of individuals, so I don't have to review the methods or the characteristics of that population. It was a qualitative study that was a qualitative arm of that same study. And we were interested in what are older Latino adults' thoughts and views on hearing aids. So we know that some of the barriers are definitely structural: cost, lack of insurance, lack of Spanish-speaking providers, but it's not all that. It's definitely some sociocultural barriers as well that are preventing that other 80% of individuals from using hearing aids. So the approach we took, rather than an interview, we asked participants, what are the first 5 words that come to your mind when you think of hearing aids? And this approach has been used in other studies, including to ask about hearing aids. And here are some of the answers that we got. Mejorar, comunicar, oír, socializar, and salud. Any Spanish speakers? Yeah. Improve, communicate, hear, socialize, and health. So we coded these as positive, neutral, or negative. Which one do you think that was coded as? Positive, exactly. But then another individual said, sordera, dificultad, enojo, desesperante, and feo. Deafness, difficulty, anger, maddening, and ugly. That one was negative, exactly. And here deafness was used as a pejorative. So each participant, we coded their 5 words as positive, negative, or neutral. If they had a mix, then we used the dominant category. This person said, no se ven mal, se ven como un chicharito, pero no el futbolista. They don't look so bad. They look like a chicharito, like a pea, but not the soccer player. Does anyone know that? Get that cultural reference? I did not when it was said to me, but I do now. So they're saying the hearing aids look like a little pea, but not this guy. His nickname is Chicharito. Okay, so we categorize them as positive, negative, or neutral, and among all of the almost 100 participants, the majority had a dominant positive attitude, which is great. And then 28% had a neutral positive attitude, and only 19% had negative attitudes. And higher MoCA scores were associated with greater odds of a more negative attitude, which is kind of counterintuitive. And I'm curious how you would interpret those results. We can talk about that maybe more in the Q&A. But I just want to compare it with other findings. This screenshot on the left is from a study that looked at India, Iran, Portugal, and the UK. And if you look at just the blue bars, that's the positive dominant attitude towards hearing aids. And it's all 40 and below. So our population had much more positive impressions of hearing aids. And on the one in the grayscale on the right, they looked at India, Republic of Korea, so South Korea, the UK, and the US. And the positive is in the lightest color on the top. So also less than 40%. And look back at ours, it was 52% positive. So a lot more positivity in our group. And so you might think, fantastic, we have such positive views, and this is really promising when looking towards using hearing aids. And that's true. On the one hand, here are some examples of positive comments. Hearing aids help me feel better, promote confianza, which is confidence, and support poner más atención, paying more attention. But some positive comments also were, son buenos para los que los ocupan. Si yo los uso en el futuro, son buenos. Si es necesario, yo los usaría. So that is, they're good for people who need them. If I use them in the future, they're good. If I need them in the future, they would be good. If it's necessary, I would use them. So to us, this was coded as positive, but for other people. So it was more of a distancing sentiment. Like they are good, helpful, beneficial on a more theoretical level, on a social level, but not for me personally. So the takeaway from that study is that they were overall positive about hearing aids, but they had a low uptake and distancing attitudes. So we need new strategies to get them from like this pre-contemplation phase to the to supporting active hearing aid use if that's what they what's indicated. So we're working with the health center to think about a peer educator model, grupos de apoyo, just like working with groups and identifying one leader of that group and using motivational interviewing to get people again from that distancing attitude to more accepting their hearing loss and the use of hearing aids. And I'm just going to briefly talk about over-the-counter hearing aids. Who has heard of over-the-counter hearing aids or something? Okay, perfect. Well, then I will review this slide then. So over-the-counter hearing aids are very new. Don't feel bad if you've not heard about them. And now after this talk, you're going to probably be noticing that they're all over the news and in the stores. Over-the-counter hearing aids were introduced in 2022. And for decades before that, you could only get hearing aids from an audiologist or an ENT or a hearing instrument specialist if you're an adult, so a licensed provider. And now you can get certain hearing aids on Amazon, at Walgreens, Walmart. So it's really opened up the market. And the goal of the over-the-counter hearing aids is to reduce cost and improve access to hearing aids. Hearing aids, like I said, are really expensive. It's the third most expensive purchase you'll probably have in your lifetime, house, car, hearing aids. And hearing aid uptake is so low. So this effort is trying to improve that access. The technology might be exactly the same as prescription hearing aids, but with OTC, you're meant to be able to use them on your own. So you download an app on your phone, you pair it via Bluetooth, and then you set it up yourself. Change all the parts, put it in yourself. So what we're curious about is, okay, so you're supposed to be able to set it up yourself, but how are people actually doing with that? How do older adults do? How do diverse individuals with different needs do? So that's why we set up this study. We had people come into the lab and carry out these 10 steps that are important for setting up and using just the very preliminary steps of an over-the-counter hearing aid. So again, download the app, pair the app, put the hearing aids on your ears, adjust the volume, clean it. And then we scored them. They can't do it at all the way to they can do it with no help whatsoever. And I was really surprised. I was supervising some of my RAs doing this, and some people did it excellent job with no help needed at all. And some of those individuals didn't even need to look at the manual, but others really struggled. They struggled with the app, and some of them they were trying to download the app, and they found themselves in the weather app or the calendar app of the phone, and they were just completely lost. And they were frustrated that the whole experience even involved an app. They were surprised that and they were trying to use a hearing aid, and now they have to figure out an app on a phone. And these were, very intelligent with it individuals. So we had 82 people, and I'm splitting them here between people who have experience with traditional hearing aids and people who don't, because literature in the past from Australia has found, and it kind of makes logical sense, that if you have experience with hearing aids in the past, that you're going to do better with OTC hearing aids. But spoiler, we did not find that. We did not find that people who have experience with traditional hearing aids do any better. We found that people who are higher educated do better on this OTC task. People with lower education, less than a college degree, had 45% lower performance compared to those with a master's degree or higher. This is concerning because OTC hearing aids are meant to kind of solve the access issue, but if it requires a master's degree or higher to figure out, that is a real concern. The reason I think the experience with traditional hearing aids didn't emerge as an important predictor is because of these steps that I mentioned here. Download the app, adjust the volume, change the bass and treble. These are not things you would have to do on a traditional hearing aid. These are things your audiologist would do for you, and you would just walk out the door and you'd be all set to go. So the people who had experience, this was still new to them. So they were struggling the exact same way. It's kind of like a clean slate. We also had a qualitative arm to this study, and we found that people frequently reported difficulties with the technology, with the device setup and handling, and they wanted more support. In this study, we did not help them at all. They could ask us for help, but we wouldn't offer it unless explicitly prompted. Of course, there's a 1-800 number for customer support, so it didn't 100% reflect real world, but how many times, I don't know if you're like me, but I do not want to call a 1-800 number for customer support. So in the future, we're exploring what is the best way to support individuals with who choose to self-direct their care with OTC hearing aids. We only used 2 devices because we had to keep this kind of reined in, but there are so many devices out there. So we used the Lexi by Bose on the top and the Lucid Engage, and then we randomized participants to one of those 2 devices. But of course, our results might be different if we use different devices. And if, this was short term. And we want to look longitudinally over time how people do in their own home, in their own day-to-day with OTC hearing aids. And we're in the process of developing test or support materials. And the Spanish language version. Initially, I wanted to do this study in Spanish, or at least bilingual, have open it up to Spanish speakers and English speakers, but there are not enough Spanish versions of these manuals available. So we were really limited to by the manuals, the manufacturer supplied devices and manuals that were offered. But in the future, we'll do a Spanish language version. Oh no, I'm wearing the same jacket as I am in that shirt. I have other clothes, I promise. This is a picture was taken at Grossmont Healthcare District. So I just wanted to highlight the importance of community engagement in this work. It's not just a recruiting tactic. It is important for learning about how to make our science better. And I'm sure you all know that, but for this topic or these topics that I've talked about today, it's especially important. What I'm working on now is noise exposure in farm workers, so a very different topic that I've talked about for you today, but happy to talk about it with anyone who's interested. And I have a K23 Career Development Award. And I'm working on that with a former AD/RCMAR pilot project recipient, Nicolas Lopez Galvez. And I'm working on an Alzheimer's Association grant with a AD/RCMAR pilot project awardee, Dr. Ariana Stickle. And Dr. Stickle and I also just submitted an R1. So I just wanted to talk about that and to thank you for your support, which has really launched my trajectory for other grant funding. And to thank my collaborators and to thank you all for your attention and your patience as I get here.